welcome to the 2020 Brain and Transcranial Photobiomodulation Virtual Summit. I'm your host, Dr. Joe Doduro. My guest is James Carroll. He's an engineer, founder and CEO of Thor Medicine, which he began in 1991. He's recognized authority on photobiomodulation mechanisms of action, dose rate effects, and the measurements and reporting of parameters. He's an expert reviewer for 5 photobiomodulation journals, which you can see in the bio. He's presented at the United Nations headquarters in New York at the Global Health Impact Forum in 2014 on macular degeneration. He spoke to the U.S. Congress briefing in 2018 on ending opioid use. He published his first paper in photobiomodulation with Mike Hamlin in 2009. He has been called by Michael Hamlin the world's leading ambassador for photobiomodulation therapy. Thank you so much for being with us today, James.
Thank you. One correction to your introduction. We're not called Thor Medicine, we're called Thor Photomedicine.
Oh, there you go. That's right, Thor Photomedicine. Yeah, that's right. 1991. Now, how did you go and, get this whole idea that you wanted to make a laser company that would, change the world? How did that happen?
Well, when I first heard of what we now call photobiomodulation, it was 1983. My mother's cat had a rodent ulcer that wasn't healing. She said, I'm going to take it to the vet and he's going to put a laser beam on it. And I thought, well, that's ridiculous. I mean, laser beams cut and burn people. Why would you put a laser on this little cat? Anyway, I thought no more about it. My mother took the cat off and, cat had the laser treatment and seemed to get better, so I didn't think anything more about it. That was 1983. In 87, I was working in a company that helped raise government grants. One of our clients was a medical laser company called Omega, and Omega were collaborating with several universities, one of which was Guy's Hospital in London, with particularly the Tissue Repair Research Unit, headed up by a very famous anatomist called Mary Dyson. She's one of the 4 main editors of Gray's Anatomy. That's the medical book, not the TV show. Oh. Mary was experimenting with the effect of light on wounds. I mean, she'd already been given a laser that had, where they claimed it's going to heal wounds up more quickly. She does experiments onto mice. She gives them partial thickness wounds, puts lasers on them, they heal more quickly. She asks herself how that works, and she started doing experiments on cells. And anyway, this is the kind of the point where I was helping raise some money for the collaboration between Omega and her, and I saw the lectures, and then I thought, hey, this is going to be a first-line medical treatment. It's going to be in every department of every hospital in the whole world within 5 years. This thing heals people. I mean, what more could you ask for? It's just what the health services need. Mm-hmm. So I gave up my job to go and work for Omega, thinking this was going to be easy. They went out of business in 91, so I started my own company with 2 engineers from Omega, and it didn't take 5 years to go mainstream. In fact, it still hasn't gone mainstream. I know it's first-line medical treatment for a few hospitals, for a few applications, but it still feels like it's in its early days, and it's now been 33 years for me now doing this. But when I started, I thought it was going to go off like a rocket.
So my question is, do you think your vision was too grand? Or, I mean, where's the disconnect? How come it took so long?
Well, multiple things. I was ignorant. I hadn't got a clue what it took to run a medical device company. I knew about electronics, but I really didn't understand medical devices. And in those days, regulations were low, so it was quite easy. I could, walk into a hospital, go to a hospital department, ask to see the head of department. You could often get a meeting. You could talk to them, and if they liked what you said, then you'd say, well, here's the laser. Why don't you try it on some of your patients? And they would say, yeah, that sounds like a good idea. And I'd come back in 2 weeks and say, did it work? And they said, oh, yeah, it seemed to do it. Would you like to buy one? And they said, yeah, sure. That's how it worked in the 1980s. It wasn't hard. By the time we started in 1990, well, it was still kind of like that through to about 1998, where they started to have more regulatory compliance around medical devices, and life started to get a little more, for good reasons, better regulated. And we got our FDA clearance in 2001, and we started behaving a bit more like a grown-up company. But it's the meeting the expectations of medical science. We were told we needed to understand more about the mechanisms, more about dose. We needed more clinical trials with humans in it. All reasonable suggestions or requirements. And then the regulatory requirements are going up. The decisions for new technologies were coming out of the hands of doctors, and they're becoming more sort of academically led practice in medicine. And as fast as we ran to where we thought the goal was, the goalpost kept moving further away, and life got more difficult. And now, as we do more business in the United States, there's insurance you've got to take care of as well. Mm-hmm. It's a very complex world, and the bar's really high. So it wasn't too, I think it's too grand a vision. This should be in every department of every hospital. All right, every department of every hospital. I'll be grateful when it's first-line medical treatment for one disease across one country. I mean, I don't know if I've explained my vision for you, but I made a New Year's resolution in 2015, and that was based on really exactly what you're saying. That was that because in 2015, having done that for how many years was it then? I mean, 20-something years at that point. I'm getting a bit worried that it wasn't going to become a mainstream treatment, to your point. And that's when I made the resolution. I've got to change my focus. This is not, I thought it would just kind of like take off by itself. It wasn't going to be difficult. And so I, made a New Year's resolution in 2015. And then that is to have this therapy become a first-line medical treatment for 100 different diseases in 100 different countries by the time I'm 100 years old. So that takes me through till 2062, because I'm just coming up for 58. So that's the goal that I set in 2015. I had interim goals of 10 diseases, 10 countries, 10 years, and short-term goals of 3 diseases in 4 countries within 5 years. And so that's what I'm up for at the moment.
Well, that's why you're the great ambassador, and it's positive that you're going to be around for the 2030 virtual summit. So I'm excited about that.
2030, yes. 2030.
So let's jump to your slides then.
So I'm founder, CEO of Thor Photo Medicine. I own shares. I pay myself salary and expenses, and I've co-founded another light therapy company. So that means I'm extremely biased, and you can't believe anything I'm going to tell you today. I started life as an engineer, so I'm not a scientist or a doctor. So you can't trust me, and I don't know what I'm talking about. So where are we at with PBM and the brain? Oh, sorry, that's a mistake. I meant to have that one. There you go.
Oh, I didn't see that one before.
So I forget what year was that movie out in?
I don't know, but they predicted that Donald Trump would be president.
Oh, well, that's right. I think I've heard that. So let's move I can't move my things anymore. So let's move along anyway. So my plan is to talk about just briefly mention a few of these things, talk about the history of this, just a few things. I know you've got a lot of speakers, and they might all talk about the history. I want to talk about the history, some people might not have thought about yet. So I don't want to do what everybody else is doing. Then we're going to talk about the many applications, but I'm going to keep it brief. I think your other speakers are going to cover that plenty. I want to have an idea of some of the devices that are out there. It's quite a spectrum, and I'm not going to do all of them. Mention something about mechanisms, and probably going to spend more time on targets. And then, I can't see my own slides because my own camera's in the way. Talk about a little bit about parameters and some of the problems there, and then we're going to talk about the path to enlightenment. So starting with the topic of history, this goes back a long way, at least to 1963. where they were sticking laser beams in brains. And because of the way I've got my organized my screen set up, I can't actually read the text in the bottom.
Most of the mice died within minutes after such experiments when the output was about 20 to 40 joules.
Yes. Now, immediately it upsets me that they talk about joules. Joules can be, you can have 1 watt of laser for 1 second is 1 joule. That's a joule of energy. So 1 watt lasers can be quite strong. You could have 0.1 of a watt, that's 100 milliwatts, and you could do it for 10 seconds. That's 1 joule. 100 milliwatts probably never did anybody any harm. I wouldn't stick it in my eyes though. You could have 0.01 of a watt. Now that's 10 milliwatts, which is pretty safe. So you could do that for 100 seconds, and that would still be 1 watt. You could have 0.001 watts and do it for 1,000 seconds. That's also 1 joule. This is like 0.001. That's 1 milliwatt, and it's considered eye safe. It's not going to hurt any rat to do 1 joule or 20 or 40 joules at that kind of power. So this is a very crude and unuseful statement saying it's 20 to 40 joules, but that's what they said anyway. But these were actually using quite high-powered lasers. They were using this as a weapon. This is a military paper, and they were able to get the right combination of high peak pulses and time, and in a short space of time, and even with that little bit of energy, but it's delivered in a very rapid rate in a very small area. They could kill some small animals or injure them certainly quite badly. But this is like the first evidence I could find of putting laser beams in the brains. Okay, so I just typed the word brain in there, and in the top left-hand corner, it says it's found 459 papers. Ignore the one next to it. 87,000 is not the number of PBM papers. I get a lot of false positives when I do searches, and there'll be some false positives in here. I can do make a quick PDF, and well, you won't be able to see it because it'll come up as a thing. But you can see here there's just hundreds of papers on PBM.
Wonderful.
So, I made it look like Google. Kind of thing. And if I was to actually search for, there's going to be false positives in here, but anyway, if I was to search for everything, I just put a star in, but just to give you a sense, it finds, it'll just do a quick calculation. Here we go. At the moment, I've got 6,938 PBM papers in here. So
that you have in your database.
Yes, that I have in my database.
I want everybody to know about that. That's your. What do we used to call that? Now we used to call it an abstract holding thing. What do we?
Yes, it just holds abstracts, and then if I find something that I like that I want to look up, then I can click on it. It takes me to my. This is not pretty. It's not designed for common use, and I can press some buttons. I make some things. I click on. It'll find the paper. It'll launch a web page, and then I can download it.
Well, I mean, people say there's not enough research or show me a paper. That's where you want to go. This is and it's not censored. Is it, James?
What do you mean what's not censored?
Well, like Google searches are censored, so they only send you the ones that you want, that they want you to see.
Yeah, good point. So we get all this data from PubMed, and then we filter it. So I suppose we haven't done an analysis of what the false positives we get is, but it's going to be something like, there's 1 PBM paper out of probably 30 or 40 papers. So we have to throw away 30 or 40 because there's one of the problems for PBM is the nomenclature. There's so many different names for PBM, low-level laser therapy, low-level light therapy, photobiomodulation. Some people just call it photomodulation. There's biophotomodulation. People have put it back to front.
Red light therapy.
Red light therapy. There's laser biostimulation is one of the early words for it as well. I've actually found more than 100 different names for this therapy now. And when we do our searches, we use 300 different keywords because it's not as simple as, many papers don't even put PBM, photobiomodulation, low-level laser therapy, low-level light therapy, cold laser therapy, laser biostimulation. I mean, a lot of them in papers have no recognizable keyword in there at all. So actually now, And I'm gradually working my way backwards in time because I'm getting more and more thorough these days than I was when I started this database back in 2008. I'm now actually search for every common laser wavelength that's being used, an LED wavelength. And so I'll search for 810 nanometers, obviously 808 and 805 and 800, because sometimes they're there, and sometimes there's 820, 830, 850 nanometers, and sometimes they write nanometers as 850 space nm, and sometimes it's 850 nm no space. I search for both kinds. So we look for every wavelength written in different ways. We use look up for misspellings of laser. Sometimes it's spelled with a Z or a Z, as you say in America. So we use 300 different words to try and capture everything that's going on in this field. And
you update that list about every week, don't you? Or every month?
Every day now. We've managed to automate it. So we've hired a programmer that sends our database to PubMed every day. And then when I've only got to look through a dozen or two. Well, actually, I do easy ones. I can click a button which finds the obvious ones. If they say photobiomodulation in the title, or low-level laser therapy in the title, or LLT in the title, then we pull those out, and those are in the database immediately. And then we get somebody to actually filter through those gradually over the
lovely
to do the hard work. We'll do something one day that makes it thing, but at the moment it's not free service, just simply because
that's an in-house. You're
in-house
deal.
Yeah,
and that's what you're going to hire a full-time librarian to modulate that, and sometime we'll make it open to
well, we'll do something. It might be that we'll offer it up for a fee. Okay, so. The range of applications, I know you're going to get plenty of other speakers going to cover this. I expect they're going to cover all of these topics here. And I presume you're seeing it now. So dementia, I mean, I first heard about treatment of dementia in 2003. There's an unpublished paper from Japan, still sitting on somebody's hard drive. Parkinson's disease, depression, anxiety. I mean, there's so much to choose from. Stroke, I mean, one of the best funded work ever in the field of photobiomodulation is the treatment of stroke by a company that's no longer around called Photothera. They previously had another name. They were called Acculaser back in the early to mid sort of 2000s, and then they changed the name to Photothera, and they raised a reported $150 million.
That's something, isn't it?
Just to research this one application. Unfortunately, well, I'm sure you've got, I think it's Paul Lapchak. Has he come to speak on your show, in your event?
Who's that?
Lapchak, Paul Lapchak.
No, he declined.
And you probably haven't got Clark Tedford, and Louise you weren't sure about either. So if anybody else is coming on has more insight, but basically they ran a small trial of 250 people, we'll say small, by PBM standards, the work we usually get done, it's quite a reasonable sized trial. And it seemed to have positive results. I seem to recall there was another one at 650 patients that seemed to be going the right way. Then they did a 1,000 patient study. And there was a futility test halfway through at 500 patients, and it seemed like there was no difference between active and placebo group. This was an acute patients and they were treating within 24 hours of diagnosis, of their stroke rather. And it was a single treatment using a continuous beam. It was a 30-watt laser. Sounds like a lot, I know, but it was over a fairly large area, so the density wasn't too great. I don't know what the surface area was, but if it was, say, 30 square centimeters and it was 30 watts, then it would be 1 watt per centimeter squared, which is quite tolerable by the skin. So you always have to keep this in mind. The density of light is an important factor. And when you say 30 watts, it sounds huge. But if you put 30 watts over my whole body, it would be nothing at all. So it's not as simple as just watts, and it's not just as simple as joules. It's power divided by area gives you density of light, and density is a very important parameter of photobiomodulation. Anyway, back to here. So stroke, I mean, they closed that company, or at least the bank that funded them, closed the company very quickly, and there was no opportunity to try and figure out what went wrong. Maybe there was something wrong with the equipment. Maybe they were all set to placebo or something, and there was a mistake in the settings. They never found out. I don't know. Somebody will know, but I don't know what it is. But anyway, it's sad that the best funded study ever, which was in the brain, failed. So, traumatic brain injury, it's been a lot of work on that, improving cognitive and emotional function, improving memory, particularly as we get older, of course, with our aging brains. Headaches, I suppose, counts as a brain treatment as well. So tension headaches, of course, it might be more to do with trigger points than treating the brain, but treating migraines, perhaps. And disorders of consciousness is a new one I've just seen. Never heard anybody describe it like that. I do recall there was an LED study on the patient with a coma, and they saw some movement in, I think it was the hands, or some response in somebody following a course of LED treatment. And I haven't read the paper on disorders of consciousness yet.
So does that mean higher consciousness also?
No, I think
it's consciousness.
I think more to do with loss of consciousness. So no, I don't think we're in competition with LSD just yet. So anyway, devices. I'm sure people can show you pictures of devices. Here's some that I've been looking at. Oh, I have to ignore this slide. This is the mistake slide I meant to hide. There's lots of different devices around. That wasn't a list of devices. I started writing and I stopped, so you have to cancel that.
Okay.
That slide, that was whatever slide number it was. Anyway, so devices. This is the first one I remember being on the market. Gordon Dougal here, British guy. Also famous. Oh, sorry. I'm looking at my next slide rather than the current slide. I'm going to stop this section now. We're going to go back on devices. We'll go back to the devices heading, which is what you presumably see now, correct?
Correct.
Good. I'm just going to take out my mistakes. Just take this mistake slide out of there. Okay, good. Back to there. Devices. This is the first device I recall seeing on the market. A British guy, Gordon Dougal, who is also famous for having supplied treatment equipment. It must be a later model or something, this equipment here. So Terry Pratchett, famous author for his sort of, I don't know, science fantasy novels, was developing Alzheimer's, and there was a lot of sort of press regarding the possible benefits of LED light to his brain. Sadly, he died. So this, I don't know if this had any benefit for him or not, but it didn't give him eternal life, that's for sure. But here's a contraption for him, and I guess that's a nearly, must be about 15 years ago, I guess. Here's the phototherapy device that I mentioned, or at least their final instrument. Here's some perhaps a slightly earlier model there on the left, and they were placing this laser in different locations on the brain according to where they had their injury. I guess that's what it was all about, but ultimately they failed. Then I suppose the next device I heard about was just not even a device intended for photobiomodulation, but there was on the brain. They got some results from treatment of depression and anxiety. There wasn't actually a legal medical device there. The next one I heard about was Margaret Naser. She was using a product made by Omnilux called the New You, and they fitted a dozen, I guess, of these, something like that, into a helmet, a skateboard helmet. You can see there Michael Ho there, who works with Marnie, wearing a helmet. And you can see also they've developed, they were using some of Ulim's up-the-nose treatments as well at that point. Then I became aware of Claire Medics, who were developing a device that actually squirted light into the carotid artery. The company closed due to they couldn't raise the funding they needed, and this was for treating Alzheimer's and Parkinson's disease. So their strategy was really to get light into the blood. Then the next one I was aware of was a paper published in the British Medical Journal. So at Boonswang, you see there in the white coat, and his colleagues there, Mary and Adele, and Donna, were using a mixture of a device, obviously our handheld system, and you see that panel in the back, a canopy device that they started using. So we're kind of arriving on the scene, and that was our precursor before we started doing a double-sided device like this, which is our whole body treatment system. And they've got some data coming up later on about the brain and the Novathor. And then, of course, and I'm not sure I've got this in exactly the right order, Margaret Naser started using Lou Lim's device, the Violite, up the nose. The original illustrations on their website, in fact, I think they're still there, sort of imply that the light is going up the nose and reaching the sort of prefrontal cortex, but there's no way that red light is a few milliwatts is actually making it to that. It may be having an effect for some other reasons. There are some encouraging devices. If you wear it for long enough, it seems it gets some benefits, and it's got to be really due to it's just getting light into blood, I guess. I mean, there are other possible mechanisms in getting light up there. The nose is innervated by the sphenopalatine ganglion, which plays some role in blood flow in the brain. So maybe that's how it works. And I've written at the bottom of the slide there, default mode network. So Margaret Naser there, Marnie to her friends, was keen on this concept of the default mode network, and that if you can be quite strategic certainly in Alzheimer's patients. And I know in collaboration with Anita, they've done some clinical trials. I'm sure somebody will be presenting some data from their work later. And then once the Omnilux New U helmet that I showed you earlier on, they ceased making that LED array, and when this was no longer available, and Marnie had patients lined up for treatment. So that's when she came to us to make a helmet. There was a concept she liked the look of, and so we actually made a real one. This is the first working prototype here. Marnie wanted switches on it, so she could switch on or off different parts of the brain, so she could also achieve that default mode network treatment that she's keen on. This is actually a picture of Han Lee, and she's not involved in the treatment and doesn't have a helmet, but she was visiting the lab, and in the top corner there you can see Jeff Knight.
I thought so.
So there, and they did send us a set of slides. I'm not going to show you all 12 slides. I'll show you the first one and the last one of an NFL player who's going through treatment with that. He had 3 treatments a week for 6 weeks, so that's a total of 18 treatments for his post-traumatic stress disorder. And so the first point on the slide there this is an emotional outburst slide. This is at the point of enrollment into the study, and then after a course of these 18 treatments over 6 weeks, and then 1 week follow-up, you can see the second data point on the slide, and then at 1 month follow-up. So this is as they say on this slide, that a score greater than 36 suggests PTSD, and you can see it's nearly up to the 67 mark on this slide, and then a reliable decrease is 5 to 10 points, a clinically meaningful decrease is 10 to 20 points, and you can see it's down to 27. So that's almost a 40-point drop there. So that's huge. And the results seem to be sustained there at 1 month follow-up. And then, and then the last slide on her list was self-rating of cognitive, behavioral, and emotional difficulties, showing a similar pattern for this player. So clearly light in the brain, as we know from multiple reasons, seems to have an interesting effect. And then you may be aware of this bucket head device. So somebody in Australia, now where was it? Tasmania, I think it was, he's obviously an engineer, had a diagnosis of Alzheimer's disease and started making his own device and then started making them for other people. And this lady here says, I'm probably better now than I was 7 years ago. So there she is wearing the LED, the light emitting bucket on your head. Not a legal medical device. I mean, if anybody else did this and started marketing it, I think they'll get into trouble. And you could argue the right thing happened. This has inspired some authorities in Australia to actually go and do some trials. And if you go onto the internet, you can find people who will actually tell you how to build your own one if you want to. So you might find some of that. And I've even heard, I've never seen one, but heard about these laser earphones. Now, I'm familiar with them for treatment of tinnitus, as we say in English. In American English, you say tinnitus. People wouldn't lighten their ears, and that's what this is for. But I did hear about some company developing a treatment for depression, I think, by lighting the brain. I think that's what they were going for. So there's quite a range of devices out there. But there's more to come. And I'm not actually going to talk about mechanisms. I'm going to leave that for others to talk about, but I'm going to talk about all of these, well, you could say they're indirect mechanisms, most of them. So I actually want to talk about the clinical targets, because people are doing more than just aiming light at the brain directly. They're not just aiming light at cortical neurons. And there's quite a long list of them. So here we are. Most people think of PBM in the brain, and they're going to just target the cortical surfaces of the brain and hope the neurons will pick some of that up and they'll regenerate in some way. And people do, histology and look at brain expression after treatment of rats and mice, and can see that there's increased levels of BDNF, brain-derived neurotrophic factor, and you get these increased cortical neuron regeneration. But when I look at some of these studies, and I'm going to show some of them later on, they're using very small levels of light that are probably not capable of getting to the cortical surface, because they're very low irradiance, very low. The density of light is very low, and I'm questioning whether or not they're actually getting to the brain. Maybe they're getting to the dura. Perhaps they're stimulating some glymphatic activity. I'm quite clear they're getting adequate amount of light to the scalp, and that there are emissary veins running from the scalp through the sutures of the skull down into the brain. So maybe light irradiation of blood and then changing blood flow or the state of some of the blood products, the platelets, the white blood cells, the red blood cells. Now we know there's free ATP sort of loose in our bloodstream now, so maybe some stem cells that are sort of have been are out in the bloodstream. All of the above.
Can I bump in one thing, because you do make a good point, but when you talk about the scalp, right? The blood that's in the scalp that's going around, you gash your head, it really bleeds. Yeah. It's not like you're cutting a main artery. Mm-hmm. But the thing that strikes me is we also have nerves in the scalp, in the skin, that can be accepting that light, doing something on that level. So even though it's a peripheral nerve, it's still a nerve that's going to get light, that can do those things. And that's maybe one of the ways maybe you grow your hair back. But
well, yes. Certainly if it was
one more thing, then you can comment, is that you have also CSF that's on your list.
Yep, good point.
There's something, it's there for a reason. So there's something in that also.
Yep, hang on.
And the superficial nerves.
So there you go. Exactly as you said, CSF. My wife is a cranial osteopath. She'll be horrified that I left that off.
My point. Good point there.
And yes, if there's obviously there's different kinds of nerves. There's motor nerves, there's pain nerves, and there's autonomic nerves, and there are the sympathetic nervous system is the ones that would have an effect on blood flow. And I don't know if there's what sympathetic nerves there are around the scalp, but I'm an engineer, not a thing. But certainly the sympathetic nervous system definitely responds to light. And it's one of the slides I didn't put in here. Do you know what? I might drop it in later. halfway
The
through.
point is, one of the things that would help this classification, James, is we kind of look at direct effects and then the indirect effects. And this is what you're talking about, because a target, like if you're studying blood flow in the prefrontal cortex, kind of to mix your stuff around, that's your target. You want to look at, let's say you look at the neurons in that area, blah, blah, blah. You're going to slice up a mouse or whatever. That's a direct effect. And so you're going to say this much light's going to have, we're trying to measure this effect on this tissue. And then the indirect effect is everything else that you must shine on to get there, if theoretically get there. So we have these indirect effects that are pushing our changes while we're only measuring direct, or examining direct effects. So that's what kind of makes it a little bit more difficult in the analysis, I think. So I think direct and indirect is a good way to describe what your stuff is here. You're going to try to hit, your direct effect is hitting the tibia, let's say. And then if you're not smart enough, you say, well, nothing happened at the tibia. The tibia stayed the same, it didn't grow, but you missed that it created this indirect effect that affected the whole body. So that's a terminology I think would be helpful.
Yes, so that's certainly in my vocabulary, indirect effects. And as you will see here, most of what I'm talking about here seems to be an indirect effect. Treating the carotid artery would be on the list of indirect effect. There's this study at MIT where they flashed light at 40 hertz and had some changes in some symptoms of Alzheimer's in a mouse or rat model, but only in the visual cortex only, not in other aspects of Alzheimer's in whatever model they were using. There's obviously the bilateral dorsolateral prefrontal cortex work that's Paolo Cassano's doing on depression. Then all the work of Francisco Gonzalez Lima and his team in Texas at Arlington. The right prefrontal cortex. I think he's also in Austin. I'm quite confused as quite where he spends his time. Anyway, so just aiming light at the right prefrontal cortex, he says you treat there and it somehow does something for it somehow manages the repair of the rest of the brain. There's obviously Lou Lim in his laser up the nose work. Like I showed earlier, I hear about people sticking light in ears. And maybe I think the laser nose work is working through the sphenopalatine ganglion I mentioned. Could have some effect on some headaches, some migraines. My wife treats often suboccipitally as an osteopath on headaches. So there's another you could say it's a direct effect on the brain. I've heard about people treating the soft palate, so back of your throat there. How about this? We know there's a connection between the microbiome and the brain, and there's obviously Anne Liebert working on the microbiome and showing interesting effects there, and who knows what that's going to do for the brain, if anything. You've already mentioned the tibia, so I've meant to put, and I'm not sure if I put the slide in, but yeah, treatment of the tibia has been shown to have effects on some symptoms as in an animal model of Alzheimer's. Hopefully I've got that slide coming up. And we've treated the whole body, so the whole body, and that does something, and I've got some measurements so you can see coming up shortly. And how about this, the stellate ganglion? So so the stellate ganglion is one of the ways it's used sometimes is for treating neuropathic pain on the face. And apparently what you do is you put so traditionally it's where you put an injection of lignocaine into the stellate ganglion. So it's done under guided ultrasound. You put a needle in. Most people don't do it. It's a specialist job. Not anybody does this. Done under guided ultrasound. It's a specialist treatment, an injection and into the stellate ganglion, suppresses the sympathetic it sort of blocks the sympathetic response and causes the parasympathetic response, leading to increased blood flow in the brain or to the face for pain relief. But it seems, and I've got some slides coming up saying that, and we know from human work that it's possible to replicate the effect of the laser of the injection using laser. You can put laser beams in here. It takes quite a lot of light to get there. But this is coming up. So there's multiple targets, and not, as you're rightly calling it, I think, indirect effects, multiple indirect effects. Who's to say where the best one is yet? So what is this one here? All right, stellate ganglion block. So in this study here, this is on patients with PTSD, saying here, patients reported greatest improvements in feeling distant or cut off, feeling emotionally numb, irritability or angry outbursts, and difficulty concentrating. And I think this is a military, yes, Association of Military Surgeons. Another one here, stellate ganglion block. This is not laser, but laser does have this same effect, as I'm going to show you at the end. So both parents experienced immediate and significant and durable relief, as it says in this study here. This is another military study, I think. There's another one down here. Month after SGB, so that's stellate ganglion block. A reduction in PTSD severity was observed, along with increases in immediate memory, recent memory, and recognition memory. Following a second stellate ganglion block, PTSD severity decreased by 57%, and memory function substantially improved with pronounced changes in immediate memory, recent memory, and recognition.
I want to ask a question.
Yes.
So the question is, they put lidocaine or some type of drug in there to stop the stellate activation.
Yes, that's right.
You take a laser beam and put it over here.
Yeah.
We don't really haven't seen, we have seen a little bit, but is it slowing the production of the stellate ganglion?
No, it's suppressing the stellate ganglion. That causes a parasympathetic response, which is the blood flow to the...
I got you. So what I'm trying to say is that, does the laser inhibit the stellate ganglion?
Yes, it does. It appears to. And I've got some slides coming up to show that as well. So that might even be the next slide. In fact, here it is. It is the next slide. So in a clinical trial, a small study, admittedly, but 8 patients with facial post-hepatic neuralgia. So this is going to be a pain study, but it demonstrates the mechanism. So facial post-hepatic neuralgia in a double-blind, placebo-controlled crossover study. So everybody ends up getting treatment either in the first batch or in the second half of the study. They're going to put what used to be called low-level laser therapy over the area of the stellate ganglion, which basically above the clavicle, aiming in sort of anterior to C6. So it's a treatment like this. So here's one of our clusters of lasers, and you put that in there like that, touch the button, and it does a treatment. This is 1,000 milliwatts. And do that for 30 seconds. They did this for 3 minutes. We can do it in 30 seconds. You put this into stellate ganglion. They compared 150 milliwatts with 60 milliwatts or placebo, and I think this was all 830 nanometer laser. And they measure forehead skin temperature evaluated by thermography. You'll see why in a minute. And pain intensity is recorded. So the stellate ganglion, I found this on the internet trying to explain this. If you block the sympathetic nerve, blood vessels dilate. This is a parasympathetic response. Circulation is improved and pain relief occurs. That's here on this third bullet point. And the bottom bullet point says, a rise in skin temperature indicates that the stellate ganglion block was successful. This study seeks to prove that laser in the region of the stellate ganglion, it's quite a long way down, that you have a rise in skin temperature. It proves that the laser block the stellate ganglion and you cause the sympathetic response. And here's the data from that. Oh, sorry, I thought I was, there's a photograph or an image of where the stellate ganglion is. And normally that's got lignocaine injection there and done under guided ultrasound. There's a lot of blood vessels in the way. It's a very specialist job. Don't try this at home. The results are like this. So on the left-hand side, pain on the visual analog scale. This is over a period of 30 minutes. The top line is the placebo group. The second line is the 60 milliwatt treatment for 30 seconds and, 3 minutes, when you can see the pain relief they're getting from this facial post-hepatic neuralgia. And the bottom line here represents the 150 milliwatt treatment. So that was 60 milliwatts or 150 milliwatts. So more power was better. So they're getting the relief. And on the other slide is looking at skin temperature. You can see T here, delta. This is the changes in skin temperature in degrees Celsius. Showing here no change in the control group. You get an increase there, small increases, like only 0.2 degrees Celsius increase in skin temperature. 5.6 degrees Celsius increase in skin temperature on the top line, and that is the 150 milliwatts for 3-minute treatment. I've tried this myself on some lucky or unlucky dental hygienist, or hygienist, as we'd say. I did a thermographic photograph here. You can see she's got picked up the temperature in the orbit of her eye, 32.3 Celsius before treatment, 24.8 on the coldest point of her face on her nose. Then I give her a treatment for stellate ganglion. I did it bilaterally. And then immediately afterwards, you get a 4.9 Celsius degree increase in skin temperature in the orbit of her eye. That's huge. And also a 4.4 Celsius degree increase on the tip of her nose there, on the coldest point. So that's using that 1 watt laser, was a cluster of 5 lasers of 200 milliwatts, total 1 watt in there, gets that increase in blood flow to her face. And a 5-year-old can do it.
So if we just talk about, we can say that the hypothesis was the direct effect was on the stellate ganglion. But again, we did a lot of other things, and I don't think that we have seen enough data to show that X amount of light is going to turn off a nerve unless you damage it with the light. So I think that there's an indirect effect happening here, and I would like to have some proof that it inhibited the sympathetic ganglion.
Yes, I mean, some other people would reasonably argue, well, surely you're putting light into the carotid artery, that might be causing skin temperature. It could be due to, well, why else would you get such a large increase? I mean, it's certainly the way they confirm a successful stellate ganglion block clinically when done with lignocaine.
You would have to be, in my opinion, you would have to have the mechanism of light creating a decrease in the action potential, which I have not seen yet. So you'd have to be decreasing the activity of a neuron, which I have not seen any data on that yet. Just a couple of inhibition papers. But that would be more of a photodynamic. You would have to be turning something off with a light is.
Well, you'd have to see another slide of mine, which again isn't part of today's thing. It's on pain, and I have a tooth extracted, a second molar extracted under laser anesthesia.
That was you, yes, I know. So that was you that did that, I know.
Moving along, so here I can't remember why I put this slide out. We were on the target on the subject of targets, clinical targets. So treating the brain directly, LEDs, lasers, targets like default mode networks, the whole body treatment. We've mentioned we've got a little bit of data to show you coming up here this is Han Lee's work. So the volunteer here is being modest and keeping some of his clothes on, but normally you'd just be down to your underwear, and was for the experiment. And they showed they have I don't know why can't I see it? Oh yes, on the left hand slide here you'll see strapped to the forehead of this volunteer a device it's broadband near infrared spectroscopy, and this detector, they're squirting light into the brain and then measuring whatever it is that comes back, that allows them to conclude that after lying in the Novathor for 10 minutes, there you see this gradual increase after about 5 minutes, increase in oxyhemoglobin to the brain. You see an immediate increase in deoxyhemoglobin leaving the brain. And then they can also detect cytochrome C oxidase activity, and that starts up almost immediately. You start lying in the Novathor and it goes up. And when it's switched off, you see that it appears to be sustained as well, and be interesting to do this for a longer study. But adding to this effect of treating the body and affecting blood flow in the brain is an interesting paper from a physiotherapist in Australia, Phil Gable. Noticed that patients who were on antidepressants found that he was treating them for musculoskeletal pain, and he found that they were not only feeling that the muscle joint, or in this case back pain, was getting better, but also that they felt better and they felt they didn't need their antidepressants. So he decided to do a little study, recruited some patients who are on taking antidepressants, treating them with our LED cluster probe, and you might reasonably say, well, hey, that isn't strong enough to get down very deep in the body. I mean, LEDs, what's that going to do for low back pain? Well, part of the point of his study is he didn't want to reduce back pain. He just wanted to give treatment with LEDs and not over the symptomatic area exactly, but he wanted to give plenty of treatment, really just to get light into the muscles and or the blood. As you can see from this illustration there, there was no improvement in their functional status. They didn't have a reduction in pain, but they did have an effect on their depression. So, and it seems to be statistically significant. Now, it's not a placebo-controlled trial, but it was you do have a kind of a sort of before and after.
James, I'm not familiar that these patients were on antidepressants. So are you sure of that they were on the drug?
Yes, absolutely.
Because I've seen this paper a few times and I saw him present it, and I did not recall that they also were taking the drug. So no one else has said that. And
I copied the text there from the paper. So no improvements in functional status suggesting group differences in antidepressant effect were independent of functional improvements or placebo effect. So, well, maybe, so I know Phil quite well, so maybe, well, I'll check that out. Certainly seemed to they felt they were getting, they're having an antidepressant.
Because I thought he was examining the comorbidity of depression with pain. And that's why he said, that's why he was studying.
That was the goal, absolutely.
So
that was the goal.
It's not that every patient in a physical therapy office, 5 patients with physical therapy who have low back pain and depression are being treated for antidepressants. This is my question. This is how I interpret it at the time. I may be incorrect. But
we can review this after the show and you can come back and put a little mark in here and you can get...
You can still show the effect, an indirect effect of these people were that they...
Yes. That's the point, isn't it?
Right.
There's an indirect effect, and that's why we've got this slide up. It makes you wonder now, how much do we have to reach cortical neurons? And beginning to look more obvious that it's not required. And as I said also, it seems that many of these devices are not even strong enough to get light to the cortical surfaces. So maybe some of the even apparently direct effects are not direct. Let me move on to something else. So a lot of people will know, but not everybody. So I'll just make this point here that Uri Oron, who's the author of the next few slides I'm going to show you, who's been known to do some demonstrate the effect of light on ischemic reperfusion injury. So this exact study, he was actually putting light, trying to treat a heart attack directly in rats, which is easy to do in rats because rats are small, but in humans we can't get the light deep enough. I don't know how he discovered it, but he stumbled across the idea that actually if you can't get the light to the target, you can actually put light into the tibia. The tibia will stimulate the release of stem cells into the bloodstream, and that the stem cells go and have this profound anti-inflammatory effect. And what we know from other studies now is that stem cells these are not implanted, these are mesenchymal stem cells, and you make them yourself. And by putting light into the tibia, and later goes on to do study where you put it in the sternum as well, because as we get older, our stems, our tibias turn to fat, and the sternum may be a better place to go as we get older. But stimulating bone marrow, because there's not much muscle in the way of the sternum or the tibia, it's easy to get light in, and the light will travel through the bone quite easily. It stimulates the release of stem cells. Here's an example. In his rat study here, number of MSCs, mesenchymal stem cells. In a control group, you see down the bottom there, not many stem cells, untreated. If you laser the heart directly, you get more stem cells. If you put laser light in the bone marrow, there's even more stem cells arriving in the heart after a heart attack. But do they have any effect? First bar is the control group, number of, there's no control, no treatment, sets a baseline, but the heart, when you laser the heart directly, you get a reduction in infarct size. And if you laser bone marrow, you get a more profound reduction in the infarct size just by treating the tibia in rats. And they repeated the study on pigs, and they got exactly the same results. So stimulating stem cells do work. He's done work in Alzheimer's, model of Alzheimer's disease here. Laser-like to bone marrow led to proliferation of mesenchymal stem cells. And sure enough, weekly treatment of bone marrow of Alzheimer's disease mice for 2 months, starting at 4 months of age, a progressive stage of Alzheimer's disease, improved cognitive capacity and spatial learning as compared to sham-treated mice. And histologically, histology revealed a significant reduction in the beta amyloid plaque. So that's interesting. So they've shown this in this is a mouse model here, and then humans have been treated now. There's been safety studies. There's unpublished work I know of they've done where they with volunteers where they put light into tibia and sternum. And they show a 300 to 500% increase in the number of circulating stem cells within 24 hours of treatment. For some people, the stem cell levels were still elevated 2 weeks later. They've done safety studies on humans, and here's the results of a randomized controlled clinical trial. This is in a heart attack, not treatment of the brain. It just goes to show that you can have an effect on humans. So these patients with ST elevation are going to get 3 laser treatments within about 3 hours of their heart attack, then at 2 days and 3 days post-MI. They get done with laser beams to the tibia. Blood samples were taken at admission and 12 hours and daily for 5 days, also at 1 month, 9 months. The accumulation of CK, which is creatine kinase, which is a marker for muscle damage, up to 5 days was 56% lower. So it didn't reach statistical significance, just 0.08, close. But troponin T was 52% lower, and it did reach statistical significance. Safety and feasibility was confirmed. Large-scale studies needed to determine clinical efficacy. And hopefully next time they will include the sternum as well, because that wasn't part of this protocol. But it shows that you can have an effect on humans just by treating the tibia, and presumably relatively in the older population, where really your tibia is supposed to be turning to fat. So, hey, wouldn't it be better if you get it to your sternum as well? So that's interesting. Parameters. Not going to go through all the parameters. I'm going to talk about what the problems associated with parameters. First of all, what I said at the very outset, and you picked up on the fact there was 20 to 40 joules used to kill some mice. And I had a little rant about how imperfect the word joules is, because if you don't describe the rate at which the light is delivered, then, if you deliver, you get 40 joules of light. You get 40 joules of light every time you lie in the sun for, I don't know how many minutes it would take, but not long. 40 joules is not a lot unless it's in a very small space and delivered in a very short space of time. And then it might be could be enough to kill a mouse. But it's got to be in a very small space in a very short space of time. Joules is too clumsy a description of dose for that reason. I want to really just highlight dose rate effects. So one of the problems with joules or joules per centimeter squared, if you don't have enough energy, it's true, you don't have an effect. And you have a bit more, you can stimulate things, and you have too much, and you can actually lose the effect or even slow things down. You can actually have some inhibitory effects. So I didn't mean to go to this bit. I took the slides from another presentation. Anyway, and I want to show you some of these effects here. So this is back to Uri Oron, who does all that heart attack stuff with stem cells, but this is from when he was just aiming light directly into the heart, 2.5 milliwatts per centimeter squared for 2 minutes. On the first bar is 0.3 of a joule per centimeter squared, and he had a small effect in reducing the infarct size in his mouse experiment or rat experiment of a heart attack. But you can have 0.3 of a joule per centimeter squared, again, in the middle one, by doubling the power, or the power density to be more precise. So if you're going to be really precise, it's the irradiance. The physicists would prefer you called it irradiance, the density of light, applied with double the density of light for half the time is still 0.3 of a joule per centimeter squared. The same amount of energy, same fluence. Joules per centimeter squared is a common expression of dose, probably a more common expression these days. So we've got the same dose twice, and you've got bigger effect. Then you increase the irradiance of the laser from 5 to 20 milliwatts per centimeter squared. So if you increased it by a factor of 4, and therefore reduces the time by a factor of 4, so it's still 0.3 of a joule per centimeter squared. And look, most of the effect is gone. Every time gave it the same dose, 0.3 of a joule per centimeter squared. We got 3 different results. Dose rate is an important factor. Here's an example.
You like the term irradiance.
I'm trying to stick to what the physicists would prefer we use, yes.
So that's correct. Irradiance has something to do with it because James, I failed math. I mean, I failed accounting. So when we get into the math part of this,
yes,
you're having a debate with the water fountain. So I work with a medical physicist because I want to make sure that the math is good. But you made it. I understood what you said just then. So
cool.
Keep going.
So this is a wound healing study. The title kind of gives away reciprocity of exposure time and irradiance. I know there's a technical words on energy density, that's fluence, the 5 joules per centimeter squared, during photoradiation. This is one of the many different names of this therapy, photoradiation, where we do that. But more importantly, on wound healing in a murine pressure ulcer model. In other words, a mouse study, ulcer study here. So they've got 2 magnets on the skin of these mice, and the magnets clamp together, they pinch the skin. You get this effectively a pressure ulcer occurring under these magnets as they pinch the skin here. And the same story is exactly the same as the last slide. 5 joules per centimeter squared every time in this example. So these are higher fluence, a higher dose. But that's achieved either by 0.7 of a milliwatt per centimeter squared for 7,000 seconds, or 2 milliwatts per centimeter squared for 2,500 seconds, still 5 joules per centimeter squared, 8 milliwatts per centimeter squared for 625 seconds. So you can probably figure that out. That's about 10 minutes, roughly, a bit more than that. Or 40 milliwatts per centimeter squared for 125 seconds. It's all 5 joules per centimeter squared. Only one combination improved wound healing in this experiment. So you can get the right dose, but not necessarily have the right effect. So there's multiple studies like this. Everybody who looks for dose rate effects finds them. And yet, when I look at the data of all sorts of studies with all sorts of wavelengths and powers and beam errors and treatment times, and there seems to be no consistency about them, they all seem to work. And yet, when you specifically look for these dose rate effects, they're there. Whoever looks for them always finds that there is at least an optimum, and very often there's only one combination that works. And then yet, the studies that don't look for it, whatever it is they do seem to work. I think that's an area of frustration for me, is how can that be true, given that every time you do a dose rate study, you see different effects. So partly I think it's because there's a lot of misreporting in the dose anyway, and therefore we're getting a lot of misinformation from there. So I don't always trust it. So laser beams, for example, are not always, rarely round, rarely evenly distributed. So down the bottom right-hand corner is a round beam, flat top distribution. It's something we made for our brain studies that we did with MGH, Massachusetts General Hospital. And that's how most beams are not. Most beams are like the top 2 up here, a Gaussian distribution beam from a single mode laser or a multi-mode laser. You end up with something more like a stripe. These are hard to measure. LED down here, a laser coming down a fiber optic, the middle one at the bottom there. What's the average density here? Some very dark areas, some light areas. But this should be simple, and there is a way that these can be measured. Physicists use something called the 1/(e² point here. More math that you don't want to hear, but worth knowing it exists. It's for reporting the average power density or irradiance of a Gaussian distribution beam. And what you need, well, not you as a doctor, therapist, but as what scientists who do medical research need to do, is they need to have proper instruments to measure the power density or the irradiance of the beam. So there's a machine here joined up to a calculator that does these measurements. When we know that in reality there's a lot of misinformation, people are using things like rulers. I meant to put on another slide here that demonstrates how light coming out of a light guide from a dentist's photobiomodulation device comes mostly down the middle of the fiber of the bundle of fibers, and a lot of people assume that the size of a laser beam or light source is the size of the aperture, and it's not. Very often the source is much smaller than the aperture, particularly when it comes to lasers. And that's not the only problem. Not using the right instrument is a problem. Paolo Casano sent me this, said, James, can you check this for me? It doesn't make sense to us. We think there's something wrong. Could you have a look? And I did. And sure enough, 70 milliwatts per centimeter squared, it says up there, was with treatment for 30 seconds, was reported as 10 joules per centimeter squared there. And yet I calculated, and you can see at the top there, it was actually 2.1. This is a very common mistake. People making elementary mathematical errors.
Right.
So
listen, I'm with you. I know the James Carroll, and I agree with you that if you submit a manuscript and you don't have the measurement from the light source in your submission, it should have a star or a question mark next to it. And I believe that's what you like to do, and I believe that that's the correct way to do it. And then you have to have the recipe, fill in the blanks so that the rest of us can understand what the heck you did. So I'm 100% with you.
If I could multiply myself and I could live on fresh air and not needing money or food or sleep, then I would make a spare piece of myself that would just, and the job would be to go off and just get involved in every clinical trial in the world, use the best power meters and do the best dose modeling for all of these things.
So we can't do that. Let's give them a good instruction manual, huh? Let's give them.
I've written a paper on this. Others have written papers on this. I look back, there was a paper in SPIE at the Biomedical Optics Society conference. There's a meeting that I'm a co-chair of the Biomedical Optics Society session on photobiomodulation mechanisms, and dose is obviously an important part of that. And for people who are listening who love the nerdy end of it, you've got to come to it. It's normally in last week of January, first week of February up in San Francisco. Look out for that. Mechanisms in photobiomodulation. It's part of a much bigger event called SPIE. They have the biomedical section at the weekend before the main SPIE event. So we normally do it on a Saturday, sometimes over 2 days for our session. It's huge. There's thousands of people come. Anyway, yeah, that's for the nerds who want to get into the weeds, that kind of thing. Very expensive. It's like $700 to attend for what's a 1 or 2 day conference. So it's not for the faint-hearted. Anyway, so I wanted to pick up on some work here done by Ethne Nussbaum, Jeff Van Zulen, who's an engineer, and David Baxter. Ethne and David are both professors of physiotherapy. And they did a review of the performance of products around Toronto. They went around with some calibrated power meters to see how many of the devices delivered 100% of what the manufacturer claimed. And you can see a few do, many were delivering nothing. Most of them were somewhere in the middle.
Nothing.
No,
zero to 100 is a big difference.
The big nothing, absolutely. Well, yes. And so as I said, field testing of clinical systems demonstrated that on average, laser systems were delivering 60% of what the manufacturer claimed, and LEDs were delivering 31% of what manufacturers claimed. So there's another problem. And we've done our own tests in light beds. This Theralite device claims it was 90 milliwatts per centimeter squared, and it turns out it was 8.7. And you have no way of knowing with devices what you're getting. So anyway, there's more problems as well. I was involved in a paper called The Dark Art of Light Measurement, Accurate Radiometry for Low-Level Light Therapy. We systematically reviewed every paper published from March 2014 for 12 months. We found 74 papers that met our inclusion criteria. Interestingly, 96% reported a positive effect. None had negative effects, but that's not my point here. really the point is to the failure to report parameters. 41% of papers in that 12-month period failed to report the power, 41% failed to report beam area, 43% didn't report the irradiance, 16% didn't even say how long they treated for. The total energy, that's the joules, 74% didn't report that. The fluence, the joules per centimeter squared, 16% didn't report that. 73% did not report testing the device with anything. Only 5% of papers reported in that period actually reported a full set of parameters.
So that is a dark spot.
It is a dark spot. Anyway, we're coming to a conclusion now. I think, what's the path to enlightenment? I do not have, the roadmap keeps evolving. So I'm sure that I've missed something here and that I'm going to change my mind next week, or certainly every year. As I said, the goalposts seem to be moving. And I keep discovering there's more that I don't know, unfortunately. I'll do a US based one first of all, and then I'll try something about other countries, because the US has got a fairly unique system compared to others. FDA. As of today, time of recording, the FDA does not actually recognize photobiomodulation. Most devices are on the market as something else. They're getting under another kind of a code. So ILY has been a common one. There's some devices which they've done what's called a 510K de novo, and this is called an NHN, the non-heating heating lamp category. If you can imagine such a thing, yes, the bureaucrats really did do that. It is the non-heating heating lamp. NHN is another category. I think when it comes to the brain, though, they're going to require a PMA. They're going to consider this a class 3 device. You're sticking light in the brain. I think that's what they're going to do. For this to be used in hospitals for treatment of things like brain injury, and stroke and things like that, these are going to take some of the strictest levels of FDA requirement, of FDA clearance. That's a tough road to go through. And the same will be in the UK and Europe as well. CE marks, getting the hospital codes. In the UK, we have something called the National Institute of Health and Care Excellence. This is going to be some of the toughest levels of approvals anywhere in medicine. The only exception I can imagine, the easier road, is if photobiomodulation is accepted as a wellness device, which it seems to be. And if you don't make medical claims, then people will probably be able to use it. And wellness may be the easiest road for PBM. They got to be careful how that's actually sold. Anyway, but that's all, folks. And this is my contact details if anybody wants to get hold of me.
Thank you. So the thing is that maybe it's not that the goalpost is moving, but it is the goalpost is moving further away. So you kick the ball to make go through the uprights. In rugby, they kick the ball through the thing, but they keep moving it further away. And I think that if you to have treat one disease, let's say they're going to treat stroke, right? Mm. And they're going to do that another stroke study because they raised a lot of money for it. Mm. And in order to put it on someone's brain now, they're going to need a lot more preclinical research that works, then get it in all the while people are having damaged brains or more damaged brains unless they have the personal sovereignty to do something about it. So I mean, it's like, who's going to pay for that type of 5 levels of preclinical research?
Exactly. And that is there's anybody who, if a company has enough patents that they can fully exploit and make a ton of money at it, then they're going to put their money into it. You put the money if you can get it out. Otherwise, it's going to come down to actual government funding of grants. And they do fund studies, though frustratingly little, given PBM. We need National Institute of Health in the United States and NICE in the UK to get behind this for getting it into hospitals anyway. Yep. And I know people use LED devices and wellness devices, and they're using it off-label and things like that. So it's kind of in use in the world, but getting it into hospitals is is a different order of magnitude in terms of regulatory compliance.
You know, as I spoke with your squad, and I think that the you know, in one sense, on one level, the vision is that a healing device will be utilized in a medical facility, and it's not really healing. You know, it's like crisis, you know, damage control, stop the bleeding type of thing. But the healing process is really something that happens with the individual. You know, the doctors do, you know, a medical practice type of thing in the hospitals is like crisis care, you know. So you know, maybe it's got to come on two levels. All boats rise, you know, if it's just utilized by more people and the information gets out there. Because how long can we wait for the research when you showed the darkness and the places that we're moving through? You know what I'm trying to get at? This is a picture that's my summary. What do you think?
Well, I don't know.
That's the highlight. So that's the goal. I'm
going to find out, though. I don't know, but I'm going to find out.
Well, I'll see you at the 2030 brain thing. I'm going to probably have a lot longer beard and a lot more gray hair, and you'll continue to have a high amount of mitochondrial activity and no gray hair. Thank you, Jim.
Thanks, Joe.